I would never give up. I would never give up on my patients. I always tell them, you can give up first, not me. So that way, you and I are totally in agreement. Next. And then we go after the disclosures. So this is a study from Israel with Schiller and Najjar showing also similar to what you said. If you, this is after using 7 drugs, you get about 20% who on the 7th drug will become a responder, have 50% or more seizure reduction. Next. And for seizure-free patients, after you've tried 7, agreeing with you, Martin, that it's almost hopeless or very unlikely that you're going to get a patient who's going to be seizure-free. Next. And so here is a list of all of our available drugs, not to be forgotten. The soon to be on our list is cenobamate from SK Life Science and Epidiolex from GW Pharma. So these are coming. We have new hopes. I agree with you. We have lots of new things to try. Next. And just to show you in our clinical trials, unfortunately, for almost every clinical trial of every single drug so far, we have about the same result, in even if they have a different mechanism of action. So lacosamide in refractory patients, you have 40% who are responders. Next. In ethylcarbazepine, 40% who are responders. And go on. Next one. And in pregabalin, preampanil, you have better with the secondary generalized seizures, but so does everyone else. So you have the same. And then you have the side effects of dizziness, somnolence, headache. You have to deal with all of that for all of these new drugs. And we all know this, and Martin and I are on the same wavelength there. Next. So my conclusion so far is no difference in efficacy of the new drugs compared to each other. You have significant side effects. The seizure-free rates are minimal. So we also need to look elsewhere to improve the plight of people with refractory epilepsy. Next. And so we usually call those patients pseudo-resistance. But I'm not sure if that's a good term. I just don't think that we have been looking elsewhere to try to understand why these people are resistant. So number one, you have the wrong diagnosis. And many of us have the wrong diagnosis many times with the psychogenic seizures or non-epileptic seizures. I find out years later my patients have been drinking a lot of alcohol or taking drugs, or they have bradycardia or asystole during the seizures. So we have to look into that. Why are these patients refractory? And then you may have the wrong drug for the wrong seizure type, which we talked about earlier today, or the doses are too high or too low, too many side effects, patients aren't taking it. And then we have to look at lifestyle. In other words, we need a holistic view of the patient, not just keep trying the one drug after the other. Stress is an enormous factor in the treatment of epilepsy. It provocates seizures, and it's a big problem in our patients' lives. Often when you eliminate a bad stress, they will become much better. Next. So the triggers, they are complicating factors. And here, if you see on the third bullet, you see all of the different types of triggers that can occur. And we have to sit there with our patients and analyze what type of triggers they do have. And often, a seizure breakthrough is caused by one of these, or even just personal lifestyle, arguing with the husband, horrible problems at work, getting up early in the morning and having to go to work is a stress that often causes seizures. Next. So the strategies are, as I see it, it's number one, when 2 or 3 drugs fail, you have to evaluate the possibilities for epilepsy surgery. We may not miss the idea that maybe some of these patients can be helped with surgery. And right now, the average is 16 years before they get to epilepsy surgery evaluation. And we should not be doing that. If we have the idea of just one drug after the other, it will take 16 years before we try everything. So after 2 or 3 drugs, you sit and think and decide, can this person go on to epilepsy surgery evaluation? I also think that seizures beget seizures in many people. And so it's easy. The earlier you do epilepsy surgery, probably the most likely you are to succeed than if you wait 16 years. And so you also have to, at the time 2 drugs fail, start the holistic approach and look at the lifestyle conditions of the patient. And hopefully you can even send them to relaxation, exercise, self-management, teach them the importance of epilepsy, SUDEP, how to understand their disease, and often they will be better just by compliance or knowing what's happening next. And so we have obvious non-drug therapies that we also must think about, and that's VNS, deep brain stimulation, RNS, and they're as effective as an anti-epileptic drug. Unfortunately, not everyone becomes seizure-free. Very few become seizure-free, but it's not a fast fix. It takes 2-3 years to evaluate the effect of these therapies. Next. And so if you see the vagal stimulation and responsive stimulation is approved 2013, deep brain stimulation is approved in Europe and Canada, they all give same effect as a drug, 50% seizure reduction in about 50% of patients, but it takes 2 years to evaluate. Big negative factor, but you have many other positive perks with this neurostimulation, not to be forgotten as a treatment. Next. And so then we have the social aspects, stress management, physical exercise, and diet. Next. So in the diet, we have the ketogenic diet, we have the modified Atkins diet, and we have low glycemic index diet. We at our center can do ketogenic and Atkins diet. That's what we mainly work at. Next, and I have outcomes are 50% reduction in 50% of the patients. Side effects are weight loss, elevated lipids, obstipation, and compliance is terrible. You know, people don't like to live like that forever. Next. But the thing is, if you look at some of the predictors of epilepsy, you see that we have these triggers that we have to think about. We have down here on the second line, the precipitating factors that will increase the risk of going down through the seizure threshold and eliciting a seizure. You have other things that we can do, like maybe exercise, just for example, fitness, which maybe can increase the seizure threshold so that the patient will not get the seizure with the same precipitator. So these are things that we can modify in the human being. Next. So there's other methods to discuss alcohol and drugs, adherence, reevaluate the anti-seizure drugs, and maybe reduce this drug burden. Many people are on a lot of drugs that probably they don't need. But as we've talked about today, we have to be very careful with this. But these are not seizure-free patients, so it's easier to reduce a drug than in a seizure-free person. Next. So I have a case. His name is Christopher, and he was born in 1992. He had seizures at birth. He had multi-handicap. And he was operated on twice in 1996 with left temporal lobe resection and extended. The resection was extended. And at 2 years old, his MR was normal, but he had late myelinization. Probably that's why he's also mentally retarded. EEG showed bilateral synchronized spike and wave activity, multi-handicapped, autistic, right hemiparesis, in a wheelchair, doesn't talk, has huge gingival hyperplasia because they gave him phenytoin when he was a child. And he tried all of these different drugs that you see, and he had a VNS. Well, this kid started coming in, next slide, this kid started coming into our hospital. And every other week, because his care people couldn't take care of him, and he was having status every other week. And everybody was frustrated, including the doctors who had to take him into, oh no, is he there again? Now what do we do? And we noticed that, and we thought of colostomy, maybe that might help, but then we noticed that often when he came in, he had urinary retention. That's something that we should be looking at. We don't even think about it. Just by accident, somebody looked, and my gosh, 2 liters. I mean, after they put a catheter in, he was much better, went home, but then he gets infections back and forth. So we had nothing else to try, and we tried the ketogenic diet. Well, he has a gastric tube, so this was really easy, and he can't complain or say anything, so he just takes what we give him, and lo and behold, he is seizure-free now for 2 months on the ketogenic diet. It's like unbelievable, and he doesn't have urinary retention anymore either. So we're all totally thrilled, and the phenytoin now is down to a very low level, and so is the valproate. And so that's my biggest success on doing something that was so unlikely for us to do, but just as the last chance we did it, bang, it worked. Next. So the AAN quality of life measurements, can find them on the internet. Well, measurement number 7 says that if a patient is not doing well and is refractory, he should be referred to a comprehensive epilepsy center. And that's one thing that you can really do instead of just trying 10 different drugs, because at least 17% can become seizure-free with more vigilance, tender, loving care, if the depression is reduced, if the patient's understanding by education is increased. Next. And so just being then you can take them into a drug trial. Now they're ready to go into a drug trial. Now they're ready to try a new anti-epileptic drug. And this can have a powerful effect, like Martin said, with the reduction of SUDEP, it increases the tender, loving care, and people feel secure. Placebo effect is enormous in a clinical trial in a positive way. And so next slide. So in conclusion, continuing to add anti-seizure drugs to treatment strategy wastes time if you don't have also another plan in the same time. And they have to be offered a comprehensive epilepsy program, holistic approach, and this includes epilepsy seizure evaluation, other methodologies, and then we have an epilepsy team, nurses, social workers, psychologists, dietitian, physical therapist, employment opportunities, going to a consultant and seeing, am I in the right job? It's enormous. So after trying 2 or 3 appropriate drugs, we have to move forward. And this does not mean excluding the use of drugs, but it's not the only thing that happens. Thank you very much.